adult focused. And today I get to talk about the hematology monoclonal antibodies. This is a task that historically wasn't that difficult in a 30-minute time frame, but we are making it much more difficult nowadays. Objectives are here on the slide. Review the basics of monoclonal antibodies, their structures and functions, as well as review dosing, toxicities, and clinical pearls. And then I'll hand it off to Cam, and Cam will talk about the fancier and more expensive aspects of cellular therapies. As we all know, monoclonal antibodies, the structure here on the right-hand side of the slide, these have evolved from a research tool to a pharmaceutical agent. It's not even fair to say in the last few decades at this point, these really are cornerstones of especially hematology care nowadays. And we have variable and constant regions, light and heavy chains, and we have now, as you'll see as the slides progress, we go from kind of these flat monoclonal antibodies to now antibody-drug conjugates and bispecifics, and even tri-specific monoclonal antibodies are coming down the pipeline. So we'll kind of allude to those as we go through the content today. I wanted to cover just the nomenclature to make sure that we're all aware about kind of how they're named in a quote-unquote rational manner. Historically, these kind of midpoint markers have been used to signify how much human or non-human protein are part of the monoclonal antibody, and therefore how typically kind of how reactive the body can be to these non-humanized proteins. Think about rituximab as your kind of classical product, where this is a chimeric or a mix of human and murine proteins. And therefore, rituximab has that kind of classical infusion-related reactions that can happen. Whereas if you go further and further down the table, further and further to a fully human or humanized protein, you have less and less of these infusion or hypersensitivity-related reactions. Now, this is the old nomenclature, and it's still kind of pertinent to now, but I wanted to introduce, or at least put in front of you, this new nomenclature schema that was approved in 2021. These will be for future monoclonal antibodies that are put through, and this is helping to identify the function or the structure of the monoclonal antibody by using a novel suffix. There are 4 that are approved for products. You have them here on the slide. I will note that there's over 100 monoclonal antibodies that have been FDA approved, but only 1 so far has this new suffix to it. Pemivibart, which is easy to say, has recently been approved for COVID prophylaxis. It's the only current product that has this new suffix nomenclature. But I did want to make sure that you were aware of this, that the MAB suffix is going away, and we will be using these 4 suffixes going forward. And they are, I consider them rather disappointing to use in clinical practice. If you, I don't really want to use, they're not going to go back to previously approved products and update them, but things like rituxatug just doesn't sound great. Rituxabart, if you want to look at it that way, doesn't sound great either, but I'm sure we'll all get used to these as well. Teclistamig would be what teclistamab would have been. Again, not a big fan, but just be aware that these are coming, and we have 1 FDA approved product at this point. Monoclonal antibodies have different mechanisms by which they elucidate their effect. They are highly effective as tumoricidal products. These products can kind of go, as we go through this, this table here, going from left to right, these can be receptor or ligand binding, leading to either cell signaling or antagonism of that signal. You can have complement-dependent cytotoxicity, where the product will go in and actually signal and lead to complement in the complement cascade. You can have antibody-dependent cell-mediated cytotoxicity, and then you can also have delivery of a payload via antibody-drug conjugates, which isn't depicted on the slide, but we will talk about kind of halfway through the slide deck. And then to add to this, at the far end of the slide deck, we'll be talking about T-cell engagers or bispecific products that bring an active T-cell and a malignancy together and make them interact where your immune system wasn't having that interaction possible previously. I will go through kind of these in a tier, the first tier being kind of these naked monoclonal antibodies, second tier being drug antibody conjugates, and then we'll finish with those bispecific products. And you can't start with the monoclonal antibodies if you don't start with rituximab. Rituximab and its cousins here, obinutuzumab and ofatumumab, are all CD20 targeting products. These are all naked monoclonal antibodies. They are directed against CD20 antigens that are on B cells. They all target kind of slightly different epitopes of that CD20, but they lead to binding of this antigen, activation of a complement-dependent as well as antibody-dependent B cell cytotoxicity, and they also have other mechanisms by which they activate neutrophils and produce free oxygen radicals. Here on the slide, I think it's important to know that these monoclonal antibodies do have very long half-lives, and even more so pertinent for these CD20 targeting monoclonal antibodies is that though they may already be gone from the body, the depletion or the activity they had on the B cells that are floating around can be long-lasting. So we expect B cell depletion of rituximab products in these patients to be in the long months range, 6 to 9 months. So though the drug may be gone and though they were treated months ago, they will be depleted of B cells for a very long time. Indications are here on the slide. As we know, rituximab and its colleagues have many off-label FDA, non-FDA approved indications, though they are used in clinical practice in many different areas, not even just in hematology practice, a lot of rheumatologic procedures and things like that. Dosings on the slide, I think it's important just to highlight that rituximab's standard dosing is 375 milligrams per meter squared. Whether that frequency is every 7 or every 21 or every 28 days really depends upon the clinical regimen that we're being utilized for, but that is kind of the standard dosing. And I will highlight obinutuzumab, which is used quite a bit in hematology as well, has this kind of interesting dosing structure where you give a lower dose on day 1, you give the 900 to finish the 1 gram dose on days 2, and then further dosing is not weight-based, it's that 1,000 milligrams dosing. Here, just to include for toxicities, I think it's important to highlight black box warnings. We talked about infusion-related reactions with rituximab. These can be mild, these can be rather severe, so it's good to have that kind of in the back of your head, especially with kind of first cycle dosing. We do a lot of things on the inpatient side to try and mitigate this infusion-related reaction concerns as well. A lot of pre-medications which are required. Moving that rituximab after cytotoxic chemotherapy to try and decrease the disease burden can be one of those things as well. So we have some mitigation strategies that we do utilize. This product can also kind of be ramped in a dosing administration process, so that kind of starts slow and kind of builds as it goes. So the rate of administration can differ based upon patient tolerability. Severe mucocutaneous reactions are black box warning for rituximab. Hep B reactivation, which is why all of our treatment plans have a built in them to assess Hep B status, as well as progressive multifocal leukoencephalopathy, or PML, is a black box warning here as well. Other toxicities are here on the slide. It is important, again, to talk about the supportive care and pre-medications that are required. And be aware with drug interactions that B cell depletion is important. So things like live vaccines and immunosuppressants are a consideration for those that have received rituximab within the last, in our case, probably a calendar year. I do want to highlight just very briefly biosimilars and the CD20 products in the biosimilar era. So we used to have Rituxan. It was the product that we utilized, and then biosimilar versions of it have come out. The question may become, are these clinically similar or similar enough products? We do have some really nice evaluations looking at biosimilars, especially the rituximab products. And they've evaluated kind of rituximab and CHOP versus a biosimilar CHOP for DLBCL, as well as you can find other publications in this arena as well, where they have found similar efficacy and safety and quite a bit cheaper for the institution as well as for the patients. So it's important to kind of highlight this as kind of an evolution of our practice and trying to cost contain in an era of a very expensive hematology care, while still ensuring that your patients are receiving kind of high quality patient disease focused therapy. Moving off the CD20 directed products, we'll move to the CD19. Tafasitamab is a monoclonal antibody, again, another naked monoclonal antibody targeting CD19, CD19 being expressed on B cells as well. And this can lead to antibody-dependent cytotoxicity as well as phagocytosis. The FDA labeling is approved for the relapse refractory setting of diffuse large B-cell lymphoma. The dosings here on the slide, it's rather complex, but I will highlight that the FDA label is in combination with lenalidomide or Revlimid. Revlimid's an oral product typically used for multiple myeloma patients, but has an FDA labeled indication here as well. You can see below on the toxicities that, count suppression, thrombocytopenia, anemia, as well as serious infections are relatively high with this combination regimen, though we do see the incidence of grade 3 or 4 adverse events decreased quite significantly when you cut out the lenalidomide component. So this may be a scenario where those who are relapse refractory, who have multiple lines of chemotherapy, who are relatively frail, maybe started on potentially a single agent and then add on the second agent as we go, or start with the double and actually drop the lenalidomide if the toxicity becomes too problematic. It's one of those scenarios where this is kind of tailored based upon patient response and patient tolerability, especially in the relapse and refractory setting. Daratumumab, another naked monoclonal antibody. This is really a cornerstone of multiple myeloma therapy at this point. This is an IgG monoclonal antibody against CD38. CD38 is highly expressed on multiple myeloma cells, and it leads to cell death via cellular dependent cytotoxicity, antibody dependent cytotoxicity, as well as that phagocytosis. It is now FDA approved, started in the relapse refractory setting, and now it's moved itself into that newly diagnosed arena as well. Dosing here differs by the product. Historically, this was a product that was weight-based in an IV product, where we had patients, taking pre-meds several days in advance. We had the first dose split into 2 separate days because of tolerability and the duration of hang. And eventually they came up with a co-formulated product with hyaluronidase, which is not weight-based. This is the subcutaneous product. Not weight-based, still requires pre-medications, but certainly better tolerated. And it's much easier to administer where you don't have a patient in a chair for 8+ hours getting that slow infusion on day 1. It's a subcutaneous product. They get monitored for a little bit, and then they're sent off along their way. And it's much improved from a patient satisfaction perspective. Nobody wants to hang out with us for 8 hours a day. And also it decreases chair time downstairs in the infusion center. Dosing is here on the slide. I will highlight some count suppression here, and this is typically used in combination with other therapies, including lenalidomide, so it is important to highlight kind of these cumulative toxicities. Infusion-related reactions are not trivial here as well, and just to highlight, the CD38-directed monoclonal antibodies interfere with cross-matching and RBC antibody screening. So if you have patients who are receiving these products or who have received these products within the half-life of a red cell, it's important to ensure that you're getting good cross-matching prior to RBC transfusions. Just to highlight really quick, looking at daratumumab and the evaluation between the IV and the subcutaneous product, which of course has been looked at, they found that the subcutaneous product was non-inferior from an efficacy and a pharmacokinetic perspective and improved safety profile in the relapse refractory setting. So not too terribly surprising with regard to the outcomes, that it would be a little better tolerated from the subcutaneous perspective, less infusion-related reactions and things like that. And patients much prefer this unless they have kind of issues with subcutaneous administration of products. The other kind of, I would consider a Me Too product here is the isatuximab product. This also targets CD38 for monoclonal antibodies, working very much in the same kind of realm and same kind of mechanism. Dosing is here on the slide. I will say that this was approved in the relapse refractory setting. It is working its way further. I think I just saw maybe last week an FDA approved regimen of a quadruplet, including isatuximab. I believe that was in the relapse refractory setting. Cam might be able to correct me if I'm wrong on that one. But this product is moving earlier and earlier. I would say we are very firmly a daratumumab institution, not so much an isatuximab institution. But those in the outpatient side in the hematology clinic can correct me if the uptake of this has been more significant in the last couple of years that I've been practicing only inpatient. Dosing is here on the slide, very much count-based and has that same cross-matching and RBC compatibility issues that the previous product does as well. And then the third monoclonal antibody for multiple myeloma. Oh, now in the VA's first-line transplant-eligible preferred regimen. There you go. Elotuzumab is our other monoclonal antibody for multiple myeloma. It does target a slightly different product target on the multiple myeloma cells and a slightly different mechanism. This targets SLAMF7 and it activates NK cells. So a slightly different mechanism there here on the slide. What I will point out here is the toxicities are quite a bit different. So though you still have the count suppression that you would expect with these combination regimens for multiple myeloma, you do have more cardiovascular effects here. So changes in heart rate, changes in blood pressure, these sort of things. So this may make you lean away from this product for certain patients with certain comorbidities. So it's just important to highlight that and be aware that this is a product that's approved in the relapse refractory setting, but I would say that it's not moving as much as the previous two products with regard to earlier and earlier as alternative therapies. Of course, my slide freezes. We'll move on here to the antibody drug conjugates. So antibody drug conjugates have roles both in the hematology and non-hematology space. A very nice little simple graphical depiction here on the slide. You have your blue monoclonal antibody, which is selective for your specific antigen on the cell surface. You have a chemical linker that can be cleaved within the body, hopefully within kind of that specific malignant cell. And then you have a payload that's a cytotoxic component with high potency. So the effect here is kind of to Trojan horse in the chemotherapy that you would historically just give to every cell within the body. You try to Trojan horse it into your malignant cell via a specific monoclonal antibody here. Brentuximab I'll use as kind of my cornerstone here. Brentuximab vedotin is a CD30 targeted monoclonal antibody, drug antibody conjugate with those three components here on the upper right-hand side of the slide. You have the IgG1 antibody that is specific to CD30. CD30 is expressed on things like Hodgkin's lymphoma and anaplastic large cell lymphoma. You have a protease cleavable linker that covalently binds to the antibody and the drug. And then you have your cytotoxic payload, in this case, MMAE, which is a microtubule disrupting agent. So you have the monoclonal antibody, goes in, finds CD30 specific cells. Those cells will internalize that monoclonal antibody and the full complex, including the payload. You'll leave that protease cleavable linker. You'll release that MMAE within that specific cell, and that will leave cytotoxic cell cycle arrest and death. Your FDA labeling is here on the slide. It has moved earlier and earlier in the Hodgkin's lymphoma regimen, so expecting things like BV-AVD. BV-AVD can be used as frontline therapy for Hodgkin's lymphoma in certain patients, kind of supplanting the old historical ABVD regimen. So this is a product that has moved earlier and earlier in those CD30 positive diseases. Dosings here on the slide, there is some hepatic dysfunction adjustments here as well. It does have a black box for progressive multifocal leukoencephalopathy, and you'll notice some of the other toxicities are not always monoclonal antibody adjacent like you would expect. There are some kind of count suppression that you would associate with that cleavable kind of payload. So you do have some of that toxicity that you would expect with more classical chemotherapy here as well. So you kind of have a mix within your toxicities that you would expect. Gemtuzumab azogomycin is another antibody drug conjugate. Same general structure here that we talked about with that cleavable linker and your payload here. In this case, your cytotoxic is calicheamycin or a calicheamycin derivative. This is directed against CD33 in the same manner of bringing it in, finding CD33 positive cells, having this internalized and cleaved and releasing the calicheamycin derivative, leading to double strand breaks and cell cycle arrest and apoptosis. Indications are here on the slide. CD33 positive AML as well as APL, which is a rare variant of AML, have FDA labeled indications. Dosing is here on the slide. I will highlight the hepatic dysfunction and holding for veno-occlusive disease or LFT abnormalities. And that's a nice pivot to the origination of this product. So even before I was clinical pharmacist, this product was approved way back in 2000 as I believe, Mike can correct me if I'm wrong, I believe this was the first antibody drug conjugate that was FDA approved. And it was actually pulled from the market 10 years later with this kind of press release up above. What they found when they evaluated the drug, the product, the outcomes was that they were having actually increased mortality for those folks who were receiving gemtuzumab or Mylotarg which is the brand name. When they reevaluated the data and they did some more clinical trials, they were able to identify the increase in mortality was associated with those who had significant hepatotoxicity, including veno-occlusive disease of the liver. They were able to kind of select out those patients and be able to find kind of that certain subset that improved outcomes. And this was reapproved by the FDA in 2017. One of the rare monoclonal antibodies that has been pulled from the market and then reapproved, which is kind of a rare subset of drugs at this point. I will point out the significant toxicities associated with this. Some of them are not terribly surprising in the setting of AML induction. You would expect things like, count suppression, hemorrhage, infections, fevers. These are all relatively expected, so it's tough to kind of parse out the toxicities of the drug outside of that liver dysfunction, which did earn it a black box warning, and of course that FDA pulling of the approval and then reapproval later. Loncastuximab is, again, another antibody drug conjugate, this one targeting CD19, again, expressed on those B cells that we've talked about. Same general structure that we've talked about as well with that cleavable linker. This is approved, again, in the relapse refractory setting for large B-cell lymphoma. I'll highlight one of the oddities in this drug product. It is dosed on adjusted body weight for those with a BMI, not a BMT, a BMI of greater than 35 kilograms per meter squared. And then count suppression and especially liver dysfunction are big players here from a toxicity perspective. But this is a nice drug antibody conjugate option for those kind of later in diffuse large B-cell lymphoma kind of subset of therapy after your standards of care have been administered. Inotuzumab ozogamicin, same general idea. This targets CD22, which is expressed on B cells. This has an FDA labeling for B-cell ALL in the relapse refractory setting. It is being investigated kind of earlier and earlier in that line as well. I will point out that it requires pre-medications and that the FDA labeling requires cytoreduction. So you really want to try and tamp down your disease as much as possible on the front end with kind of pre-phase chemotherapy or hydroxyurea or steroids or vincristine in some way to try and decrease your tumor lysis risk with this drug kind of in the upfront setting. A big player here is peripheral neuropathy. So that's one of the things that we really want to highlight with inotuzumab. I would say that this is more of an inpatient drug. I think it's utilized still on the outpatient side. But this is kind of more in that relapse refractory setting with like significant disease burden, and we really want to monitor these folks closely. And we're getting to the end of the drug antibody conjugates. This is polatuzumab. Polatuzumab has an FDA labeling in combination with bendamustine and rituximab in the Pola-BR regimen, if you want to think about it that way. This targets CD79B. This is, again, targeting those B cells in diffuse large B-cell lymphoma. Has the same payload in MMAE, which, again, disrupts microtubules in that disease. And has the same toxicities that you would generally expect from our previous discussions of these monoclonal antibodies with the drug antibody conjugates with LFT abnormalities as well as count suppression here as well. And then just for fun, I wanted to include tagraxofusp, partly because it's fun to say, the other part because it's really an odd product. It's not technically a monoclonal antibody. I will highlight that, so I'm kind of outside my window here. But it's CD123 targeted. It's a fusion protein of IL-3 fused to a catalytic domain of the diphtheria toxin, which can be internalized, leading to the inhibition of protein synthesis and apoptosis. It does have an approval in blastic plasmacytoid dendritic cell neoplasm. So I did want to kind of highlight this as a weird product. Again, not technically a monoclonal antibody, but certainly in that kind of payload idea in the hematology space. As you would expect with something that funky, it has a lot of pre-medications, requires inpatient administration for at least the first cycle, requires some albumin requirements prior to the first dose, has a black box warning for a high rate of capillary leak, and has a lot of other toxicities, including significant hepatotoxicity, fevers, hypersensitivity, kind of a really weird, really funky drug. So I wanted to make sure that you at least seen it before and be aware that it exists. And you can always tell your friends that you're playing with diphtheria toxin if you get bored. The bispecifics here, just to finish out really quick, We'll use blinatumomab as our poster child because this has been the FDA approval for the longest time. Really think about it as kind of two different monoclonal antibodies that you have structured, one against CD3, one against whatever your malignancy might have. In this case, blinatumomab is a product that it kind of combines an anti-CD3, which targets cytotoxic T cells, and in this case, CD19, which targets B cells, malignant cells, hopefully. And you put them together so that your T cells really were ignoring your malignancy, and you are taking an active role in bringing your malignancy and your T cells together to make them interact and hopefully lead to cytotoxic death of that malignant cell. That's really the general idea with these bispecifics. We talked about the blinatumomab. Here it is as an approved product in the relapse refractory B-cell ALL regimen. It's also approved in MRD positive B-ALL, and it's moving earlier and earlier in the frontline setting as well. Dosing's very odd. Dosing's here on the slide. For those that are in the relapse refractory setting, we start as 9 micrograms per day continuous infusion for a week, and then escalate to 28 micrograms per day thereafter. And it's a continuous infusion for 4 weeks with 2 weeks off. It's a very odd dosing, rather cumbersome from a patient perspective because they're attached to a pump for 28 days. That part of the aspect is really not that fun. And I would say that since you have a slow infusion of product, there's a lot of kind of logistical complications that come with that. It does have a black box warning for life-threatening cytokine release syndrome, or CRS. Cam will be talking more about CRS in the next portion as part of CAR T-cell therapy, so I won't touch on that too much. But I'll just point out here that CRS rates are pretty high. Neurotoxicity is very high as well. LFT abnormalities, as well as infusion-related reactions, are quite complicated. It requires hospitalization for the initiation and dose ramping, requires pre-medication with high-dose steroids, and again, you've got a patient who's got a continuous pump for 28 days and all the logistics associated with any of your patients that you can think of that are maybe not so reliable from their drug therapy perspective. It adds an extra layer of complexity. And then I'll just blow really quickly through the recent approved bispecifics. Teclistamab is really kind of our workhorse here for multiple myeloma. It binds to BCMA, which is expressed on myeloma cells, and that CD3 on your T cell, brings them together, creating a cytolytic synapse. Approved currently in the relapse refractory setting. Dosing's here on the slide is a step-up dosing, which requires hospitalization for these step-up doses, as well as a re-ramp if the dosing is interrupted on the outpatient side. So tiny doses, kind of subcutaneously in a kind of 2-day increments. And then once the patient tolerates that, they're administered every 7 days and potentially up to every 14 days on the outpatient side if they tolerate the drug. Black box warnings for cytokine release and neurotoxicity, which Cam will address much more in depth in the next setting, is really why these hospitalization requirements exist for this product. But I would say, again, this is, in the relapse refractory setting, a workhorse for us here at UW. The Me Too for teclistamab by Pfizer is elranatamab. I believe we do have this on formulary. I believe our utilization is much less here. Has the same requirement for hospitalization for ramping and re-ramping. Generally the same vibe with regard to dosing here on the slide as to what that looks like in practice. And also has a dosing schema where you can get it every 14 days instead of every 7 days if you receive at least a partial response after 24 weeks of therapy. So it does have kind of that built-in de-escalation of dosing for those who have a response. Talquetamab is, I would say, teclistamab's cousin, made by the same drug company, targets a different receptor. So in this case, it's GPRC5D, which again is expressed highly on multiple myeloma cells, and this is also approved in the relapse refractory setting. It mirrors the previous 2 bispecifics in its dosing schema that is required for hospitalization, for ramping and re-ramping as well as its black box warnings for cytokine release and neurotoxicity, which really are T-cell related toxicities. I do want to highlight talquetamab's kind of odd toxicities in addition to that. So this is kind of here on the slide, and we won't be able to go through the details in depth, but you have the slide deck. But talquetamab does have some odd toxicities, including kind of dyschezia, dysphagia, stomatitis, weight loss, pretty significant with these patients. rashes, including macropapular rashes and things like that, as well as nail-related changes. So what I would argue is that this is probably not the kindest drug from a toxicity perspective in the relapse refractory setting, though it does appear to be pretty darn good. So we're still working on optimizing kind of how to give this and how to make it tolerable for our patients. But I just wanted to highlight kind of these weird toxicities associated with talquetamab and the receptor that it's targeting. And then very quickly, the bispecifics for the B cell population. So glofitamab is a bispecific that targets CD20 on B cells, same CD3 on the T cells. It's approved in the relapse refractory setting for diffuse large B-cell lymphoma, where your patient will receive obinutuzumab day 1, and then after that, it's just glofitamab going forward for these patients. It's an IV product that has a black box warning for cytokine release and also requires hospitalization for that first dosing and re-ramping if therapy is held on the outpatient side for any reason. Epcoritamab, same general idea here. This is a subcutaneous product, though. Also approved in the relapse refractory setting for diffuse large B-cell lymphoma, also has black box warnings for neurotoxicity and cytokine release syndrome, and also requires hospitalization for that first dosing and re-ramping for that risk of CRS. And then finally, mosunetuzumab, bispecific here, IV product as well. This is approved only for the relapse refractory follicular lymphoma population. Does have a rate of CRS in the 44%, but does not require hospitalization per the package insert in the FDA. So that seems that rate of CRS of 50% or higher puts you in a hospitalization per the FDA, whereas anything less than that will not require it. Just something for you to be aware of with your product selection. With that, I'll turn it over to Cam.
Thanks a lot, Jason, for that excellent overview. Just give me a second to make sure I get my slides shared. It had been years since I'd seen Jason lecture, so I'd been looking forward to it, and he really delivered. I gotta say, there's always more to learn, and so I appreciate his expertise. Also, thank him for letting me borrow these slides. So my name's Cameron Ninos. Today we're going to be talking about, or I'm going to be focusing on chimeric antigen receptor, or CAR T cells. Also maybe a couple nuggets of other immune effector cells at the end if we have time. Just as a brief background for where I practice, I was in stem cell clinic as a pharmacist for about 5 years. Last year, we had this new immune effector cell or cellular therapy pharmacist position. So I've been in that since then. So really focusing on some of the structural aspects of building a CAR T program, as well as other new immune cell effector cells that are coming on the market, in addition to the direct outpatient care for these CAR T patients. The objectives for the learner walking away from this today is to be able to review the CAR T cell manufacturing process, which, because they're living cells, has some other complications that we don't see as much with monoclonal antibodies or other biologic products, as well as how they work. Discuss our CAR T products and what they're used for, and then summarize some CAR T toxicities as well as management strategies. So CAR T cell is a chimeric antigen receptor is what CAR stands for. And so that means that it's a receptor that's been chimerized or really merged so that it targets a specific receptor on cancer cells, so either CD19 or BCMA in terms of our approved products. But then it's introduced to a T cell. And so that's where you get this living drug component that is able to provide active surveillance against the malignancy and really replicate to provide that anti-tumor effect. So it's almost a next step of combining the immune system with the monoclonal antibodies that Jason just discussed. So from a manufacturing process, this starts then really before leukapheresis with just obtaining prior authorization, which is a whole deal since these drugs are usually in the $500,000 range. Once we get that through, then we leukapherese patients to remove their white cells. Those white cells then are sent off to the drug manufacturer, where that chimeric antigen receptor is actually introduced via viral vector. Those cells with the receptor present are then expanded within culture. There's a variety of quality checks that occur. So if products don't pass those checks, then we might just not be able to offer them to patients. We might need to recollect a patient, or we might be able to offer the drug to a patient on an expanded access investigational protocol. If a drug passes all those, then we're able to receive that back from the manufacturer as part of the FDA labeled indication. And patients undergo lymphodepleting chemotherapy, which is typically cyclophosphamide with fludarabine. The goal being to really clear out the bone marrow and the immune system, so that those CAR T cells can replicate and begin working against the cancer. So once we get the 3 days of lymphodepleting chemotherapy, we have 2 days off, and then the patient's infused with the CAR T infusion, which, similar to our stem cell infusions, is a little bit anticlimactic, looks kind of like a blood product, tends to infuse over 15 minutes or half an hour. And then after that, we're going to be monitoring the patient while the CAR T hopefully does its thing, inducing cell death. So looking at our FDA-approved CAR T products, I put these into 3 different overviews or sections. This one I would call the leukemia section. So Tisagen Lechlucil, or Kymriah, is a CD19 product, first one on the market. This one I really think is the pediatric product. It has approvals in adult lymphoma, but due to not meeting its endpoint in some of those trials, our lymphoma group really doesn't use it very frequently, but it is the preferred product and the only licensed product in our pediatric population. I like to call out the co-stimulatory domain for these products. 41BB for our CD19 directed CARs is going to be a little bit of a slower replication process. So we might not see as fast and aggressive of toxicity with CRSs and ICANS as we do with the CD28 products. From a pre-medication standpoint, being kind of a manufactured product, there is a risk of infusion reactions. A big call out for CAR T products is that we really want to avoid any corticosteroids that aren't specifically being used to treat toxicity. So that means we're not going to have them as our standard pre-medications in order to prevent infusion reactions. And we want to try to avoid them for infusion reactions and other indications unless we're specifically using it to treat toxicity. And then from a wholesale acquisition cost standpoint, a little interesting that it's indication specific pricing. And so that ALL price you can see over the $500,000 mark. It actually needs this product, because it's high enough, needs to be specifically approved by a vice president every time we purchase it. On the other side, we have brexucabtagene autoleucel, or Brexucel, otherwise known as Tecartus. This one we use in both of its indications. So it's indicated for relapse refractory B-cell ALL in adults, as well as in mantle cell lymphoma. Now, this is a CD28 targeted product. So with that CD28 targeting, we're going to see earlier and more aggressive CRS. And then as part of that, with the CD28 products, even though the data we have is actually with Axicell, we will use and have been using corticosteroid prophylaxis, 10 milligrams for 3 days starting on day of infusion, really to try to reduce and delay that CRS and ICANS. That is off-label. It's not something that there's a lot of data to support, but just because we've seen such severe toxicity with this product, it's something our lymphoma group has embraced just to try to mitigate that toxicity. So moving on to our lymphoma products. So we're still on the CD19 directed at this point, and we have Axicell, or Yescarta, as well as Lysacell, or Breyanzi. And here's where that co-stimulatory domain really affects your patient selection for who will get what product. So Axicell has a really nice manufacturing process. Whenever we leukapheresis a patient, we tend to get that product consistently within about 28 days. However, with that CD28 co-stimulatory domain, we do see early and more severe CRS and ICANS. So our lymphoma group tends to reserve this product for, in the words of Dr. Pofoli, patients who could tolerate an auto. If you can't tolerate an auto, then you're going towards Lysacell or Breyanzi. So this one is that 4-1BB co-stimulatory domain, tends to be better tolerated, later CRS and ICANS, as well as being lower grade. And then with Lysocell, from an indication standpoint, in addition to DLBCL second line, similar to Axicell, we also see that it, in the past year, it's received approvals for CLL as well as mantle cell lymphoma. So that mantle cell lymphoma, I think our docs are pretty excited about, to be able to have this better tolerated product in order to for those mantle cell patients, rather than just offering Brexucell. The one challenge is the dosing. The manufacturer likes to market that it's supplied in a specific ratio of CD4 to CD8 cells, and maybe that's why we get some nice efficacy with that reduced toxicity. However, we do have less consistent manufacturing. So it's about 25% of the patients we treat with this tend to be out of spec, or 25% of the patients we collect are out of spec. And so that results in at least product delays, and sometimes means you can't even infuse a patient with the drug. So a bit of a trade-off from toxicity to manufacturing with that. We're avoiding prophylactic corticosteroids on this one because we don't have that higher grade CRS ICANS. And then from a pricing standpoint, pretty similar to Axicell. And then finally, we have our BCMA-directed products that we use in multiple myeloma, idacabtagene vicleucel, or Abecma, otherwise known as Idacel, and then siltacabtagene autoleucel, otherwise known as Cilta-cel. These both target BCMA. The Cilta-cel manufacturer will market that it has multiple binding sites. And so there's always this balancing that maybe Cilta-cel looks a little better from a data standpoint, but we definitely see more toxicity with it as well. And so our myeloma docs, that's what they're really balancing, is that fitness of patient. If they have more comorbidities, they might lean toward Idacel. If they're younger and more fit, they might lean towards Cilta-cel. Pre-medications are going to be standard here. We don't use prophylactic corticosteroids with either of these products. From a CRS timing standpoint, despite both having that 4-1BB co-stimulatory domain, we do see a lot earlier CRS with Idacel. It's over 90% occur within a day of infusion. Cilta-cel actually has a more delayed CRS ICANS onset, which is different than our lymphoma products, where earlier onset was worse. Cilta-cel, we get a delayed onset CRS ICANS, but we tend to see more toxicity with it. And then pricing, you can see, is similar there. So whenever we talk about CAR T toxicities, couple broad buckets we can discuss before we go into detail. But from there is the concern, because you're introducing a viral vector, that these cells could be oncogenic themselves. And so the FDA has released an alert about that. Then we have our cytokine release syndrome, which is due to the mechanism of action of the drug with inducing that cancer cell death via cytokine release, as well as neurologic toxicity. And then we have that CAR T infusion where we need to pre-medicate. It's a foreign product, so there is a risk of allergic reactions. And then finally, we talk about on-target off-tumor toxicity. And so this, for example, with our CD19 products, is due to that CD19 targeting of the CAR product, we see B-cell aplasia, prolonged hypogammaglobulinemia, and resultant infections. And there can be other types of that on-target toxicity as well. So the first CAR T specific toxicity that you've heard alluded to plenty throughout the presentation is called CRS, or cytokine release syndrome. It's really this inflammatory syndrome from cytokine elevations, as well as the other immune cells' response to CAR T infusion. The severity can be correlated with several things: increased level of cytokines overall, non-specific inflammatory markers such as ferritin and CRP levels, and then tumor burden, as well as if you actually measure the CAR T kinetics, the higher the level of the CAR T cell, the more severe it tends to be as well. So the nice thing about CRS is that it does tend to give you a warning flag of when it's coming, and that's a fever. And so the majority of our CAR T patients are infused in the outpatient setting, and we say, let us know whenever you have a fever and we'll bring you in. After that, there is really a laundry list of other symptoms you can see there that it can really affect any organ system. We are going to narrow in a little more due to the grading system on really hypotension and hypoxia. So about 5 years ago, the American Society for Transplantation and Cellular Therapy was kind enough to get together and agree on a universal grading system for CRS. And so this is what we use institutionally and typically used in clinical trials now. And so once again, we see that fever is that first warning sign that qualifies you for grade 1. After that, we're really just focusing on blood pressure and oxygen saturation. So grade 2 is where we're seeing someone who responds to fluids or has a low flow nasal cannula. Grade 3 is someone who's requiring vasopressor or high flow oxygen. And then grade 4 is where you're in the ICU, multiple vasopressors, as well as positive pressure ventilation. So from a CRS treatment standpoint, there's a lot of different really algorithms, and each product has its own recommendation. And then some national bodies like ASCO and NCCN have some recommendations as well. But the way that it's evolved is that most centers kind of have an algorithm that they use that applies to all products. And I think it is helpful to both see this from a table as well as a flow sheet standpoint. This is our newly minted approved algorithm that we approved just earlier this year. And so for grade 1 CRS, we're mainly just looking at Tylenol. We do say you can consider tocilizumab for patients at high risk for severe CRS. In practice, we've been using that for over 90% of patients. So most of our physicians are evaluating that patients are at higher risk for severe CRS, and so they are pulling the trigger on that tocilizumab. The thing that's a little more that's intentionally vague in the guideline and variable between physicians is whether or not to give a dose of dexamethasone, where I'd say it's more 50-50 at this point. So you can either just give the tocilizumab, or some docs give a dose of dexamethasone as well. Then you monitor the patient. If they don't improve, then you might administer the dex then. If you're looking at grade 2, or if a patient isn't improving, so these are people who are requiring fluid support or low flow oxygen, any grade after that, you're automatically getting tocilizumab. And then you can see our dexamethasone dosing kind of steps up with each grade. So we start at 10 milligrams every 12 hours for grade 2. For grade 3, it's going to go up to 6 hours, 10 milligrams every 6 hours. Or grade 4, it's 20 milligrams every 6 hours. And then the other new medication we're introducing in for grade 4 is going to be anakinra. And that's where we might go if a patient is still not improving, even with high-dose anakinra and dexamethasone and previously receiving tocilizumab. We might go to things like high-dose methylprednisolone as well. And we'll keep moving then on to the next CAR T specific toxicity, which is immune effector cell associated neurotoxicity syndrome, or ICANS. You will get plenty of alphabet soup throughout this if you haven't figured that out already. So this is a neuropsychiatric symptom or syndrome that can happen after CAR T infusion, thought due to cytokine diffusion into the brain, as well as CAR T cells directly trafficked into the CNS. It can start as headache or tremor. However, it can lead to more severe signs such as delirium or seizures. So the grading score for this is really this two-step type system. So the first step is this ICE score, immune effector cell associated encephalopathy. And the value of this is really being able to identify patients earlier on before they're having something like seizures or completely obtunded. And so you can see the components of this are orientation to year, month, city, hospital. I'm always very thankful they don't put president in there because that's become quite contentious. And then naming objects, following a command, writing a sentence to assess that tremulousness, as well as attention. And then you can see the ICE scoring there, where if someone's 0, they're grade 4, versus with those less points deducted, they might be lower grade. And then that is factored into our overall ICANS grading, where we can see at the top, if you're just missing 1 or 2 points on that scale, you're classified as grade 1. If you're missing 4 to 7 points, you're grade 2. And then for grade 3, you're maybe barely scoring on that, and then you're starting to have these other clinical signs. Or grade 4, you're really unable to perform the ICE assessment, and you might be completely unarousable. Pediatrics, I do like to call out, just has their own unique system for children based on age, because you can imagine they might have trouble writing a sentence if you're a younger age. So you will see a different score there for young children. So from an ICANS management standpoint, we have the same type. We have a table as well as a flow chart for patients. The one notable thing you'll see here is there is no tocilizumab in the ICANS treatment algorithm. The idea being that if CRS co-occurs with ICANS, then we can use tocilizumab, but tocilizumab does not penetrate the CNS. So if the patient isn't actively having CRS, we should not be using tocilizumab to treat ICANS. So that means our mainstay is going to be dexamethasone, where you can see we might just give 1 dose with that early grade ICANS, and then escalating once again from that Q12 hours to Q6 hours and higher dose with high dose methylprednisolone for ICANS grade 4 ICANS that doesn't respond initially. The other thing you'll see introduced a lot earlier on is anakinra, where we have a consider starting with grade 2 and a recommendation to administer it with grade 3, which is really a practice change in the past year or two that's really been solidified. And then the new kid on the block for ICANS treatment is the intrathecal treatment. The trials that have been done are still quite small, so it is controversial, but I feel like we've had a fair amount of success with it. It is built into our algorithm. Some debate about why it actually helps, whether it's just the physical act of relieving pressure versus administering the intrathecal hydrocortisone versus actually giving chemotherapy. And in our algorithm, we say you can consider intrathecal with grade 2. It's recommended intrathecal hydrocortisone with grade 3, if feasible. And then we'd recommend chemotherapy with that intrathecal for grade 4. This is just documented here for your reference. I won't go through it in detail just due to time. I did want to mention other CAR-T toxicities. And I guess just to respond to Thorin's question, that is correct. So for anakinra, we are currently administering prophylactically for patients who experience CRS. So essentially, once they get admitted to the hospital, for those 2 CD28 products that we've had the most complications with. So that's Axi-cel and Brexu-cel. So just to restate that, if you get Axi-cel or Brexu-cel, you'll get 3 days of prophylactic corticosteroids. And then once you spike your fever for CRS and get admitted, we will use prophylactic anakinra, 100 milligrams twice daily for the duration of your CRS or until it tends to improve. The rationale there being that CRS is one of the main risk factors for ICANS. It's really rare to see severe ICANS without any preceding CRS. So we're trying to be able to treat the patients that would benefit from anakinra while not asking patients to pay $1,000 daily out of pocket for it, since we haven't had a lot of success with insurance coverage. Thanks, Thorin. Moving on to other CAR-T toxicities. We've been seeing more and more of these, and so they've been an increasing challenge to treat. We have immune effector cell associated hemophagocytic lymphohistiocytosis-like syndrome, or IECHS. So this is a HLA-like syndrome that occurs following CAR-T infusion. there was a guideline published last year that has great information on this if you want to dive more into it. It's challenging because it is distinct from CRS, so it tends to occur after CRS resolves, but it does have some co-occurring things such as fever. However, we see that it does tend to be associated with very high ferritins. We've seen patients in the hundreds of thousands. And I'd say this is one of the toxicities that we're really struggling with the best way to treat. Because even though we know the first line management is corticosteroids with or without anakinra, we might see some modest improvement, but it seems like something that can last for months in patients. And so it's a challenging balance of that immunosuppression and trying not to have your patients die from infection while managing these cytopenias and this ferritin that you see continuing to rise. So I'm hoping in the coming years we can come up with a better system for how to manage it, but I'd say we're really struggling with it right now. Immune effector cell-associated hematotoxicity. So cytopenias are the most common toxicity after CAR T, and early cytopenia from chemotherapy isn't surprising and isn't that difficult to manage so long as it recovers. Where this becomes really challenging is whenever you get to day 30, 60, 90, and you're still seeing patients who might be transfusion dependent or failing to recover their neutrophils. It's where we have used things like stem cell boosts. And I think there's a lot more investigation into that area for how to try to help patients. And so infections then are really going to be our leading cause of non-relapse mortality following CAR T, due partially to the two preceding toxicities that we discussed, in addition to things like the hypogammaglobulinemia from on-target toxicity. And so we have a wide variety of mitigation strategies for that, our prophylaxis, acyclovir, levofloxacin, fluconazole, and sulfa. So somewhat similar to our stem cell transplant in that regard, with that variable cell recovery and the factor of the immunosuppression from other toxicities, maybe requiring something like mold prophylaxis or prolonged anti-infectives. Growth factor is controversial, but we are using it more frequently. IVIG, also somewhat controversial, but being used more commonly. And then these patients do receive vaccination similar to the series that our transplant patients go through, starting at day 90. So just, I think, some warning things that I want people to be aware of since these are newer products. So the end of last year, we had FDA alerts for secondary malignancies, such as T-cell, CAR T positive lymphoma, as well as the cilta-cel manufacturer submitting a black box warning for MDS and AML associated with its product. The FDA does firmly say that these products still, the benefit outweighs the risk, but there are challenges with them being on the market. Also, in the past few months, there's been non-relapse mortality published with cilta-cel up to 15%. This was 7,600 patients across 18 clinical trials and as well as 28 real-world studies. So very large data set, and I think that's significantly higher than what we would think of with an auto as acceptable for an auto transplant. And so just keeping in mind, these are quite toxic products that we're still learning more about. Cilta-cel there, you can see followed by our CD28 lymphoma products with Brexacel and Axicel. So next generation, we're looking to improve access. I mentioned how onerous that manufacturing process can be, so it'd be great if we could have off-the-shelf or allogeneic CAR T that we don't need to collect a patient individually. That hasn't yet come to market, but there is still hope for that. Improve control for whenever we have those severe toxicities with things like inserting EGFR so that we can administer a monoclonal antibody to turn off the CAR T. And then improving kind of our tumor targeting as well with something like a dual CD19, CD22. So it's an area for active investigation that I'm sure we'll see more coming soon. I'm about out of time. I did put these in just for kind of your info. These are new products that are on the market of novel immune effector cells. We don't offer them currently, where there's discussions ongoing about whether or not we will. But if you're interested in that sort of thing, you can review them. So I'll just end it there and pause. So thank you for your time, and be happy to answer any questions.